Thank you, Martine, and I would like to thank Shockwave for organizing this symposium and having the opportunity to report on the clinical data that are already existing with the reducer. I think James already covered this, and also Tommaso, what we need to know, what we have to do and use the data. What is important is safety, efficacy, durability, and we learned about the mechanism of action and how can you do all that. Well, you need trials for that, you need patients, and you need to gather all this information. And there are also all sorts of trials that you can imagine. Of course, there is the first-in-man data, there is a randomized control trial, prospective cohorts, retrospective analysis, and meta-analysis, and of course registries, and that teaches a lot about safety and efficacy. And just to give you a quick overview here, or what is already available, let's not forget that the first publication was back in 2007, so this is already 27 years ago, where Dr. Banai had his publication in JACC. And it was on the cover of JACC. So it took quite some time then to organize or design a trial at that time, because there was few believers in it. And then we started 2010 with the first inclusion in the COSIRA trial, which then led to the COSIRA paper in 2015. And since then, the number of patients enrolled in trials, prospective and also retrospectively, has only increased. There were a lot of physician-initiated trials. There were registries, and then also a meta-analysis by the group of Dr. Banai in Tel Aviv. And then, of course, recent attention by the Orbita Cosmic paper that was published in Lancet this year. So I think there's we need to know what kind of patients fit in these trials, what kind of patients have we included in these trials, and already mentioned, we're looking for patients with severe angina. They have refractory symptoms despite the anti-anginals, and I don't want to discuss the number of pills that are used. Is it 1, is it 3? I think it's up to the discretion of the investigator. But I think it's important that they have to be on medical therapy. And of course, at that time, epicardial disease with no revascularization options, and there had to be a proof of ischemia. Is it feasible? Well, we now have already a lot of data from COSIRA, the meta-analysis, the Reducer 1 registry, where half of the data were published in Neurointervention, and then, of course, Resource. I don't have to give you the number, you can see them, but all these numbers show that the procedure was very successful, and that there was a high rate of success in all these patients. About safety, same story. If you look at COSIRA, 1.9% of periprocedural complications, again 3% in the meta-analysis, Reducer 1, and the Resource 5.7. But almost no major complications. There was no bailout surgery, no periprocedural death. There's no tamponade, and there was 1 periprocedural stroke. So all in all, I think amazing safety data. And here we're looking at does it really work? Well, I think let's have a look at the let's say the trials or the registries that we have and that we are most familiar with, which is COSIRA, the registry Reducer 1, and the Orbita Cosmic. And when we look at it, again, this is just the number of patients and what kind of patients were enrolled. You see the severity of these patients that were enrolled into the trial. But the main message here of COSIRA 1 is that this is baseline, and you can see patients were in group 3 and 4. No CCS class 1 or 2 was allowed. On the left, you have the treatment arm. On the right, you have the control arm. And you can see that what we achieved at 6 months, that 71% of the patients improved by at least 1 class and 35% improved by at least 2 classes. And you will see, remember these numbers, because these numbers will come back over time. when you look at the meta-analysis by the Tel Aviv group, again, you look at 40% improved by at least 2 CCS class. So that's again a very similar number. And the Reducer 1, which is a multi-center prospective cohort registry, again, for the first time looking at it, in the real world, what is happening to these patients. That's not randomized, there's no placebo group, and we enrolled 400 patients. Data were just presented at ACC this year. Again, for this trial, we also had 20% of the patients who had non-obstructive coronary artery disease. And again, the classical exclusion criteria, but patients also, not only a 3 and 4 class, but also were allowed to have class 2. And the goal is to have 5-year follow-up. Again, this is very similar to the other study, the COSIRA-1, and a meta-analysis where this is the type of patients that were enrolled. And again, we're looking at the results here. And this is baseline. As I mentioned, there's class 2, 3, and 4 were allowed. And then this is the result. So again, very similar to what we have achieved in all the other trials. 70% improved by at least 1 class, and 24% improved by at least 2 classes at 6 months. Now, when you look at it, what kind of patients do really benefit from this therapy? And this is, again, the baseline in the registry in the Reducer 1 study, where we see what happens at 6 months. And you'll see, again, there's improvement of 45% in class 2. And what we notice is that the higher the class you're having, the better the chances of an improvement. CCS class was 79% improvement, and class 4, 85% improvement. So the higher the class, the better the reaction that you have to the reducer. And so I shared with you the 6-month data, but then the question becomes, and also the question was already raised, what about sustainability? Are these results durable? And we looked at it in the Reducer 1 registry. As I mentioned, we're looking up to 5 years. We already have preliminary data at 5 years, but this is just the data to illustrate at 3 years what we have in all these patients. And you can see that in terms of, you have a significant drop of symptom improvement. Patients in class 3 and 4, they go from 72 to 81%. And at 3 years, 11% of the patients are still doing very well. And again, for the SAQ score, when you look at the Seattle Angina questionnaire, what really comes down to how do I feel as a patient is what is my quality of life? And you can see that this is a significant improvement. Again, very sustainable at 3 years. So that's very, very encouraging. And then, of course, we had the latest trial, which was published in the Lancet this year. Basically, again, the same. It's very similar to the COSIRA-1 study. The difference between the two is that one, it was patient-reported, whereas in COSIRA-1 it was physician-reported CCS class. And this was patient-reported. So patients had an app and they could daily send their daily reports. And then the second difference, of course, was also the MRI analysis, which was already discussed by James. So I don't want to go too much in detail here, but again, a very similar type of patients that was enrolled: epicardial disease, refractory angina, no options for revasc. And again, same kind of patients that were included. And the results I don't have to show, basically because you know them. Again, a significant reduction in daily angina episodes. Now, they did a little bit more, and I don't have to share this with you because James nicely discussed this. But I think also in terms of when does that all happen? We look at 6 months, and very often we get the question, unlike PCI, am I going to be better tomorrow? No, it takes a little bit of time. It needs time before you have reendothelialization. There's some thrombus formation below the struts. And of course, you need to have reduction in flow or induce a pressure gradient. And you can see, and this is also elegantly demonstrated in this trial, that it starts basically after sort of a couple of weeks, and then you have an improvement at 3 months and a sustained effect at 6 months. So this is very nice data again, and I think, again, this illustrates how these results every time come back across all the studies that we have done. From the very first Banai publication in 2007, COSIRA-1, physician-initiated trials, meta-analysis, registry, Orbita Cosmic, it's all about the same. There is a high procedural success. The change in CCS class is significant and is always around roughly 70–75%. And in terms of class reduction CCS number 2, at least you get a 25–30% reduction. So in conclusion, I think in summary, is it safe? Yes. Do we have efficacy? Yes. Is it durable? Yes. How does it work? Well, we know it works. Not quite sure the details, but I think we may have to do some additional testing, but we know how it works roughly. And I think all in all, this is very fascinating data that really confirm what we have been doing for so many years. So definitely a place for these patients with refractory angina. Thank you.
So we have time for 1 or 2 questions. Yes, so Tommaso, bring you the microphone. First, the lady.
Thank you. Fantastic, amazing. And I'm thinking of being a woman, and I've seen so many women with microcirculation disease and severe angina and unable to do things. What was your response on the 20% of the patients that had no epicardial disease, that have microcirculatory disease, or how did you describe the patients?
Yeah, these patients were allowed in the trial. They need to have proof of ischemia, not necessarily showing that there was microvascular angina or microvascular obstruction, but they fulfilled the criteria of inclusion. And their response is similar to what all the other people with epicardial disease. But there are specific trials looking at, and Renil can also, and Tommaso, who are actually both looking at studies with microvascular or INOCA or ANOCA patients. And there is also early data from Dr. Banai in Tel Aviv, where they have published their data on microvascular, or INOCA, I should say, with the reducer. So maybe one of the three can just comment on that.
Great. So I think we've got a clear idea that this device is working at the level of the microcirculation. It seems biologically a plausible intervention for impacting on the microcirculation. And that's the question, though, that we are testing. And as James alluded to before, I think before you start putting a permanent device into somebody with a structurally normal heart and unobstructed coronary arteries, we better have a pretty good level of evidence to support that kind of activity. And which is why we are doing a randomized sham control trial in patients with angina, unobstructed coronary arteries, and evidence of reversible ischemia, proven by both non-invasive testing by quantitative MRI perfusion, as well as invasive physiologic metrics.